What is going on, everybody? It is Mark Cargill, lead faculty and CEO here at Modern Pain Care, where we make you the complete clinician. Coming at you with another episode of the Modern Pain Podcast, and this one has been spurred on by shockingly, a social media post made by our partner here, Jarod Hall, who we'll bring on in a second. But talking about joint mobilizations, and joint mobilizations, obviously pretty much a cornerstone of what we're taught in our manual-therapy training in physio school, and I know we see some osteos and some chiros and different things. So, a little controversial post, but I don't think it needs to be controversial. But of course, anytime you talk about things that are very held sacred in a profession, we get, emotions start rising and discussions can get heated. Although I didn't see anything too bad on his post, which was surprising because every time we've ever talked about manual therapy, there's usually some folks. But the folks on the post said, hey, I'd like a little bit more of a fine print readout on this thing. So here you go. Here's a podcast. We'll talk about it. So let's bring in our partner here. Hey, Jarod, how are you doing?
Man, I'm doing well this morning. I think this is going to be a fun one to talk about just because it's come up a couple of different times when I'm teaching in school. It's come up in different, social media conversations and all that sort of thing. So it'll be good to actually, talk about it in podcast format where we can get into a little bit more of the details and maybe unearth some of the nuance with the post.
Does nuance sell on social media is my question. Can you be nuanced? You just got to take positions and pound your fist and go with it. Isn't that the way you roll with it? Not saying you roll with it that way, but
that's what you do. Just black and white. That's it. That's how everything works. There's a simple yes, no answer for all things.
Yeah. So that's why basically we do the podcast, is to see if we can kind of cut in the middle of the dialogue that usually, I'm glad I'm not a young PT coming up, because I wouldn't know what the hell to be doing, because I got one guy saying diametrically opposite of the other guy, and who do I believe? And, I can tribe up with somebody and wear a t-shirt that supports them and their social media presence. But maybe we could bring the patient into this a little bit, and then maybe we could just find that little middle ground that often exists in the vast majority of topics, and maybe there's some thinking and reasoning that go into when we move joints in specific directions, or maybe we don't. But that's what we'll get into today. Can you kind of lay the groundwork of your post and kind of what you put out there on social media, so we can kind of get into the nuts and bolts of the discussion?
Yeah. So a little bit of background, actually. I was in the local PT program a few weeks back. I was helping grade what we call a skills check, where we have the students come in and just kind of off the cuff, we say, hey, we're going to give you 3 examination techniques and 2 manual therapy techniques. And, I could give this to you in a lot of different ways, and you need to be able to talk me through what you're doing. You need to be able to demonstrate good body mechanics, good hand placement, et cetera, and know what you're doing with these. So it's really kind of rapid fire type thing where we have these students come in, and the students at this point, they're still taught in the curriculum, traditional arthrokinematic principles with your roll, slide, and glides, and say when when you go into external rotation, well, that really stresses the anterior capsule. External rotation of the shoulder, that really stresses the anterior capsule. So if you need to improve external rotation of the shoulder, well, you need to do a mobilization or a glide that kind of stretches out the anterior capsule. So you would do a P to A mobilization for the glenohumeral joint to increase external rotation. And what I will say is that the professors there don't necessarily ascribe to this closely, but they understand that it's still on the boards quite a bit. So they have to teach it, and they know that the students are going to go out and they're going to interact with clinical instructors that really follow these rules to a T. So we have to teach them so they're prepared for that and understand, some of the historical thought processes and that sort of stuff. So I just got kind of frustrated with it a little bit because I'm testing students on things that I don't believe in at all. And so I went to Twitter, and I put out a little Twitter post, and I said, we've got to stop teaching posterior mobilizations for restricted internal rotation of the shoulder, inferior mobilizations for restricted, for abduction, and anterior mobilizations for external rotation and all the like. Arthrokinematics are trash, not very good, the traditional thought processes. And joint capsules are really tough. You aren't loosening a joint with your wiggles. Mob directions don't really matter. You're simply talking with the nervous system and causing a change that way. And Twitter, is you're limited in characters. So I had some abbreviations and I had some acronyms and I had some, little emojis and stuff to shorten the characters to actually get the post out. So Twitter's not a medium where you can get into a lot of depth. So then I reposted that on Instagram. A lot of, conversation spurred from there. And multiple people asked, hey, can we like talk about this deeper? Do you have a video on this? Or is there a podcast episode where you guys talk about that? And I said, there isn't yet, but there's about to be.
Yeah. And here we are. Here we sit today talking about it. So, yeah, the arthrokinematics, the convex concave rule. I was reared in a manual therapy program. I remember in school that was very much kind of. I mean, my teacher was Dan Vaughn, who if folks you probably don't know, a lot of folks may not know Dan Vaughn. He recently retired a few years back, but great influence because he was very eclectic. He never said you have to do it this way. The only way you can look at a human is through this lens, but he did have a lot of that stuff because, as with the program you're teaching in as well, we got to meet the board requirements and make sure folks are prepared for what they're going to see out there in the clinic. And there is a lot of arthrokinematics and very minutiating ways of looking at how people move and trying to break people down into. Anytime you tell me a rule, and with humans, I really struggle just because humans, as we know, and definitely as we hear about pain, there's very rarely do they consistently follow any specific rule. But curious, kind of your thoughts, and kind of as you've kind of perused the literature, and I know we will link a few articles in the show notes here, so if you guys want to check out some of the stuff, there's one article I think we both were talking about. It's the Johnson article of 2007 on adhesive capsulitis and joint glide. That was one of the ones I think that spurred a lot of discussion when it came out way back when. I still remember 2007. That's 14 years ago. But anyway, that I remember that being a very conflicting, kind of, because I was still probably entrenched in the midst of that was 4 years out of school for me, and I was still very tightly held to the beliefs that very specific movements and very specific mechanics and different things were the key to helping people. But I'm just curious if you can kind of go over a little bit of that and maybe some of the other things you found as far as like in the convex concave world and some of the things that have questioned some of the validity and treatment utility of those rules, I say in quotes.
Well, so as far as arthrokinematics, I remember learning it in school and thinking this seems kind of weird. If a convex is moving on a concave, something different happens than if a concave is moving on a convex. Why are these rules opposite at the same joint? Whether you're talking about the proximal segment moving on the distal segment or the distal segment moving on the proximal segment. So if I bend my elbow, right, I've got that old concave moving on the convex, if it's open chain. But if it's closed chain, well, then I've got the convex moving on the concave, right, because I've stabilized my ulna and now the humerus is moving. Why are there different things occurring? Why do we think there's different things occurring at the same exact joint segment, performing the same exact movement? So that was the first thing. I was like, well, that's weird. That seems strange to me. Like, your elbow is your elbow, your knee is your knee. If I do a seated knee extension, I have the same type of movement going on that, if I do a squat, like my knee is flexing. It shouldn't be like rolling and sliding and gliding and stuff and doing different stuff. It's just a joint interface, right? So that was the first thing. I was like, that's a little weird. That just from a common sense or third party perspective, that seems a little funky. That seems like we made up some interesting rules to layer on complexity there. And then next, when you actually talk to like biomechanists, are over, like, so Andrew Vygotsky, one of the smartest dudes I've ever spoken to in my life. And I tried to pick his brain on some joint mechanics one time. And the oversimplifications that we teach in PT school or Chiro school or whatever are laughable when you actually talk to a biomechanist about what's truly going on in a joint when they do three-dimensional modeling and they do like bone markers and stuff like that to see, what's really happening at the subtalar joint, what's really happening at the talocrural joint, and et cetera. So our arthrokinematic oversimplifications are that's exactly what they are. They're dramatic oversimplifications that don't necessarily exactly reflect truly what's going on. So those are two things that got me questioning things. And then you mentioned the Johnson study, right? This is where you come into practice and you say, well, this person has adhesive capsulitis, but for some reason that makes their shoulder mechanics different than if they just have normal restricted external rotation. In normal restricted external rotation, you do an anterior mobilization, but if you throw in some adhesive capsulitis, then you do a posterior mobilization. So that's what takes care of it. It's totally different in this one isolated condition. And then take that deeper. If you look at adhesive capsulitis, the actual pathological tissue is the anterior capsule. It's the fucking middle glenohumeral ligament and the rotator interval on the front of the shoulder. So if anything is restricted, you should be doing a P to A mobilization in that particular condition. But what we see is, surprise, surprise, the exact opposite works better for for frozen shoulder. So that's when you actually take it into practice, and the exact scenario in which your arthrokinematics should make the most sense when you have a verifiable tissue limitation on the anterior aspect of the shoulder is when you do the opposite technique, right? So that's looking at it from an arthrokinematic standpoint. From a biological plausibility standpoint, I like to take stuff even back further than what does it look like in practice and just think, is this even logical, right? So we typically teach these things and say, well, you need to work on their posterior capsule of their shoulder, or you need to work on the posterior capsule of the knee, or whatever it is, right? All these arthrokinematic, all these mobilizations are often taught with the target tissue being maybe the joint capsule. So you're taking that joint surface or the edge of the joint and you're pushing it up against the capsule and you're mobilizing it and you're trying to loosen up the posterior glenohumeral capsule or whatever it may be, right? Let's say for somebody with internal rotation deficit of their arm, we'll call it GERD, right? They've got glenohumeral internal rotation deficit, and a lot of times that happens in an overhead athlete, and we're saying that their posterior capsule has gotten really thick and really tight from all of their overhead, athletics. So we need to mobilize on that posterior capsule to improve their internal rotation and normalize that GERD. A capsule is really, really strong. It's like super strong. It's connective tissue, right? We're talking about thick, dense connective tissue with the rotator cuff and the glenohumeral ligaments that are continuous with it, that really only a skilled anatomist can dissect out consistently, right? Rotator cuff tendons, glenohumeral ligaments, joint capsule, they're all very continuous with each other. So we know that tissue is pretty robust. And what we know from stretching research, let's take muscles and stuff like that aren't as robust of a connective tissue as like capsules and ligaments and that sort of thing. And there's a ton of different researchers, Magnuson and Freitas and Kubo and all these people that have done all these stretching research studies that show, hey, bro, you can stretch that hamstring or that calf or that whatever really hard for several minutes a day for weeks at a time. And we're really not sure, maybe just a little bit, potentially, possibly in some certain circumstances, you actually increase the length of a muscle. So we know that stretching doesn't really seem to change tissue very much, and that's a pretty aggressive load a lot of the times. Like, you're forcing your body weight into it, you're like really leaning your body over it, you're yanking on a strap or whatever it is, you're holding aggressive stretches for long periods of time, and that doesn't seem to change connective tissue length. Then we're going to say a little wiggly with my hand on your shoulder, it for 30 seconds 3 times is going to lengthen out that tight capsule, that tight connective tissue. It just doesn't have a lot of biological plausibility to me. And I apologize, I got on a little bit of a rant, Mark, but I'm gonna step back and I'm gonna allow you to jump in here and kind of maybe post some of your thoughts.
No, I think we agree on the vast majority of that. I think Yeah, the fact, the lengthening tissue thing, I think, is one of the things as we talk to, students and mentor folks, as far as going in with that mindset of like the human's so, moldable and sculpt, we can sculpt them with our hands and do that. One, it makes no sense if we encounter a lot more brisk loads if you're doing any high level, weight training or anything than what some dude leaning on your shoulder would be. So if we were that, moldable with our hands and things could stretch that easy, we would be like Gumby out there. But, yeah, I think it's just more helpful to look at mobilizations like we're working on a sensitization process around a joint usually, and you can modify sensitivity through various symptom modification strategies. Some of it is passive movement application, and sometimes it works to poke into the sensitivity. Sometimes it works better to poke away from the sensitivity. Which one works better? The one that works better for the patient in front of you is really, I don't get too caught up in that. Now we do see clinical patterns arise where, more often than not, mobilizing posteriorly in frozen shoulder patients can maybe get a better change in range of motion than posteriorly. If it gets a better change with inferior, just don't get caught up in the minutia of like, and talking to people about, you're a car part that I've just fixed and I've lengthened, and it's all these, faulty tissue narratives, that sensitive tissue narratives. And we do know as frozen shoulder progresses, things come from a more very inflammatory sensitization process to more chronic sensitization that kind of correlates with somewhat with some limited restrictions, but our ability to, change those in the midst of a within treatment session, I think that those abilities have been greatly overblown. Yet I just looked at, and I love the folks at Physiopedia, so don't start banging on me. They're great, and I would highly recommend you check it out if you need any knowledge in the PT world. But there was a presentation that was done from somebody, I think, in the Mulligan system, and there was still, I just looked at, said, well, what are they saying in this presentation? I don't even remember what year it was, so it could be 5-10 years ago for all I know, but still a lot of things about lengthening tissues with our mobilizations out there. So that narrative still gets spun quite a bit, and I just think, again, I think it's more helpful because it's more biologically realistic of what's probably going on, as far as like the sensitization versus, hey, we got a shortened limited tissue. That's the crux of the matter. And again, in some cases, I think, like I said, with a mature frozen shoulder, possibly definitely some limitations. But then again, the mobs that should supposedly lengthen said tissue that you alluded to, we're moving in the completely opposite direction a little bit, which, well, some people say, well, that puts tensile load on the anterior capsule when you're pushing things posterior. I don't. It's a gray area, but that's where, again, if you have a clinical process that allows you to validate if things help the person in front of you, but when we say it works and it helps, we just gotta be careful of what our thinking is of behind what's causing that help to happen and what's causing that change in front of you to happen. It's probably a lot more than soft tissue changes and things like that. So hence, maybe you can try some different glides. Are they always necessary? I think sometimes we've made them necessary based on tradition and the way we teach it, but maybe there's some other things we could be doing with patients besides having them lay on tables, that they could self-mobilize and do things that, if you do the same test, treat, retest, you see the similar changes in range can happen, and then maybe, hey, the patient can drive that change. And but again, there's a lot more to the treatment encounter than that. I've drifted afar as well into the dialogue, because I think getting too paralysis by analysis with some of the mechanics and things can kind of prevent you from, just getting in there and trying to get people moving in value directions that probably will be engaging some sensitive directions. And then knowing the specific presentation in front of you, maybe it's a calm it down, protect phase, and then eventually we need to expose that thing back to loads. And some of that could be passively driven, but obviously that's not where your patients function in life. So that needs to be something that eventually gets in the rearview mirror and gets people, off the tables and in life. So that's my thoughts, I guess, on it. Jared, anything else you feel like would help folks? Because, students look at this like, well, what the hell do I do then? You're telling me everything I just taught was taught. And then you get students who get mad and become challenges in the MSK instructors class because they're questioning, which I think is good to question. I think there's probably a proper and professional way to do it, not be that student in class who becomes like the one who wants to have a question and discussion on everything. Maybe you find private time that doesn't occupy your fellow students whole class talking about it and arguing with it. But anyway, anything you would recommend to students who are trying to, or even early career professionals, or maybe professionals who are navigating the existential crisis that all folks trained in manual therapy get to when they start reading science? But what would you recommend?
Well, one of the things I want to say is, before we go any further, is I am positive that I will get the question, or I will either get the attack, well, Jarod, you don't do manual therapy, you suck. Or, well, Jarod, now that you're saying all this stuff about joint mobilizations, like, do you even do them? Well, and the answer is actually yes. I still do some joint mobilizations. I just don't think about all of these hyper specific, arthrokinematics and, directional specific things when I'm doing them. I take a person's arm in my hand and hold it as comfortably as I possibly can, get them in a position that feels good, and I apply some rhythmic mobilizations to their shoulder in the direction that they tell me feels the best for them. I want to try to reduce protective muscle guarding. I want to try to get them to relax. I want to try to decrease their pain so then we can move that shoulder afterwards. 98% of the time, I do an anterior to posterior mobilization of the shoulder joint just because that tends to feel really good for people. They tend to like it. I might do a little bit of lateral distraction or long axis distraction and that sort of stuff. So, yes, I am putting my hands on people. Yes, I'm passively ranging their shoulder. Yes, I'm providing some joint rope mobilizations in a rhythmic manner that is relaxing to that person and in a way that feels pretty good for them, to try to allow their nervous system to calm down a little bit and allow for more movement, allow for us to get more movement, and maybe to decrease their pain. So just because the premises that you were taught for a technique don't hold up doesn't mean that you can't still do that technique, and it can't still have value as well. We've just got to maybe quit putting ourselves in a little box and constraining our thinking to some of these traditional narratives that aren't necessarily helpful and limit maybe more critical thinking and that sort of stuff. So I would like to say that.
Yeah,
You held up your finger.
yeah, I did. You caught that. Thank you. But yeah, I think the big thing is what you're thinking when you're doing these things. Are you like in your brain about like, oh my God, is this millimeters going this way or that way? To me, you're missing the true interaction that needs to be going on. Hey, as I'm doing this, Mrs. Smith, how's this feeling? Does this feel like I'm more kind of this, which direction you might fiddle with? Maybe it's not perfectly inferior, it's a little inferior and posterior, but you feel, and that's kind of based out a little bit more on the Maitland, where you adapt technique to what's giving you the desired symptom response, not what's your arthrokinematic PhD, biomechanist brain telling you. I think we work with humans and pain responses that aren't always going to be consistent. So fiddle, handle it well. I think, I see students who do mobilizations and they're used to practicing on pain-free partners and they don't provide that inherent comfort and context and things that allow a patient to relax and allow them to kind of, maybe bump into a sensitivity with a lot more relaxation and better chances of top-down positive modulation versus, the student who's just kind of like I was for early on in my career, like a bull in the china shop, just trying to again, so caught up in how mechanically things were functioning that I forgot, hey, I got a living, breathing, painful human under my hands. How do I fit this as best to that unique person that day as possible? And there might be some consistent directions. Like you said, posterior glides often feel good to patients. And that's often the better reliable thing is the change in front of you in the N=1 situation, not, like, ooh, I think this is posterior gliding better. Yet the patient, again, patients don't give a shit about what those glides are doing, what they want to move and feel better. So if you focus on that, I think you're going to get a better change with patients. You'll be able to put manual therapy in a much better perspective versus, stripping the patient who's sitting on the sidelines. Are you going to do something here? Are you going to be just continuously analyzing, millimeters versus focusing on getting me back in my life and, applying techniques that feel more on a symptom response, not a paralysis by analysis, mechanical mindset, which I think just you miss the boat if you're too caught up in your brain on a lot of that stuff. I think we've railed on this enough, and I hope it wasn't railed because you can see Jarod and I actually touch patients. I also get so frustrated. Well, Mark, your hands just must not be good enough. Oh, Mark, you must not do manual therapy. I would agree. I do manual therapy daily. It's just, I don't get too caught up in getting paralysis by analysis over, arthrokinematics. Don't do a lot of the fancy, arthrokinematic glides, a lot of physiologic glides loading into sensitive directions. Understanding conditions versus where they are on the protect versus expose continuum that we teach, and test it with patient response, not with textbook p-values. I think patient response I'll take all day every day, and not to say we can't use that textbook p-value stuff to help us maybe get better understandings of what has the best chance to work, but in the end the patient's going to be the decider on if that works, and you need to fit that to them and not vice versa, which I think too often when you're in a very minutia-laden, rule-driven, anytime there's a rule, it's just, again, like I said earlier, I think that to me puts you at risk for being very caught up in your research and in your mechanics versus fitting yourself to a unique human in front of you. So get away from rules. Use them for thinking aids, but I wouldn't let that anything be a rule of mine, because people ain't going to follow a lot of rules a lot of time. So any other parting thoughts you have, Jarod?
No, I was just going to say, I think we've broken our 20-minute podcast rule today. But this is good. These are the conversations that I like to have, because they're driven by the interactions that I'm having with real students and real clinicians. And it's what makes running our mentorship program fun. It's what makes physical therapy fun, is actually getting into these reflective conversations and getting into critical thinking and trying to make stuff make sense for patients. So this is what keeps me going. It's not the other stuff. It's what I enjoy.
Yeah, and Jarod brings it up. If you're ever interested in going a little deeper and talking about this stuff, these are the discussions we love having with students, and again, putting them in their clinic with patients and letting them test these theories out, and letting them kind of say, well, what works better, getting paralysis by analysis over mechanics, or fitting your techniques to unique humans in pain, and ideally having better outcomes. So if you're ever interested in having a discussion with us, if you want that kind of coaching and mentorship in your practice, don't hesitate to reach out, modernpaincare.com/supercharged, and we can have a discussion and see if coaching and mentorship is well in your practice. Of course, we'll be answering questions and these things as we kind of move forward. If you have any thoughts, suggestions, or things that you'd like to hear us talk about, don't hesitate to reach out via social media, Instagram DM, Facebook message. Keep it polite. And if you have differing views, that's beautiful. Let's have a discussion over them, and let's see if we can come to some middle grounds, which often exist if you look for them, versus sitting on one side of a fence and throwing stones at each other. I think we can help a lot more patients if we try to find that middle ground and the nuance that often exists. So I appreciate your time today, and it's a little longer of a podcast, so we apologize, but we'll be back next week talking about probably some other manual therapy related topics, and we will see you then.